I am going to pass the ball to my colleague, Liz Buck, and we will get started.
Great. Thank you so much, Diana. Hello, everyone, and thank you for joining us today. My name is Liz Buck, and I am a program manager at CSH in our New York office. Today's session is on using integrated teams to provide high quality and coordinated care to highly vulnerable patients. And this webinar is sponsored by HRSA. CSH is a national nonprofit organization. We're across the country, and as I mentioned, I'm in our New York office. At CSH, it's our mission to advance housing solutions that deliver three powerful outcomes. First, improve the lives of vulnerable people. Two, maximize public resources. Three, build strong, healthy communities across the country. CSH is a HUD technical assistance provider and also a HRSA technical assistance provider under the Federal Department of Health and Human Services. Our HRSA technical assistance program includes webinar series focused on health and housing partnerships, for which this care coordination webinar certainly falls into. We provide direct TA to health centers and continuums of care. We provide regional trainings and peer-to-peer learning. Our specific target is to build partnerships that can address the needs of those in our communities with limited access to primary health care and for individuals who frequently overutilize emergency systems like the ED. Our major partner on this work, or a significant partner on this work, is the National Healthcare for the Homeless Council, who was instrumental in planning this webinar. And so I am on the left, that is my picture. I'm a program manager at CSH, and I'm joined with really a stellar panel. We have Janine Skinner, Senior LPN Care Coordinator, Licensed Practical Nurse Care Coordinator at the Camden Coalition of Healthcare Providers in Camden, New Jersey. We have Mary Pellick, a Social Work Coordinator at the Camden Coalition of Healthcare Providers, to give her perspective on this work, as well as Ed Stellan, Executive Director at Heartland Health Outreach in Chicago, Illinois. So today, we hope that folks leave away with gaining some insight in three different areas. We hope folks learn about the components that make a successful care coordination model. What are the best practices and what have we learned in the field? We want individuals to get a more technical understanding of the roles of different team members and what the lines of responsibility are. We also want all of you out there to hear from models in the field and try to apply some of the lessons that they've learned in your own work. We will be hearing, again, in particular with two community examples, Camden, New Jersey, who has a Medicaid ACO and has been very much involved in care coordination for a long period of time, and then Heartland in Chicago, Illinois, an FQHC that is really early in the development of their care coordination model. So these are our topics here today, and this is how we'll plan to spend our time on the webinar. First, I'll do a brief overview of the need for care coordination and some of these key components that we're seeing for effective care coordination across the country. Second, we will look, each of our panelists will briefly describe their organizations and care coordination models. Camden is a Medicaid ACO model, and their members include all hospitals within the city, primary care, behavioral health, and supportive housing partners and providers there within the city. At Heartland Health Outreach, Ed will describe a little bit about their organization programs and the development of their care coordination program. And then third, I'll be facilitating. We'll spend the bulk of our time really delving into the nitty-gritty of the program. So I'll be facilitating question and answers among many of these key components. And then finally, we will also have time towards the end for open question-answer session. So you can feel free to write questions as you have them in the chat box. And so this is a chart. We in healthcare tend to hear the term superutilizer used a lot, and we're always focused on the small percentage of patients that account for the high percentage of cost. And we know that this is true. We know, looking at these charts, looking at our Medicaid population, 5% of patients account for nearly 50% of healthcare spend. But we find there's more when we dig into this population, certainly, that those who have very significant high healthcare costs, these so-called superutilizers, have very high housing instability. A recent Health Affairs article found, looking at an integrated health system in Denver, that nearly 30% of these high-cost patients were homeless. We find this really consistent with examples across the country. This population has significant medical and social complexities, including multiple chronic healthcare conditions and experience with significant trauma. And this is a sort of dizzying chart that we think displays a lot of the challenges that exist in healthcare delivery and that exist in social service delivery. And so imagine how complicated these systems are, trying to get to behavioral health and primary care and neurology and physical therapy. You and I doing that, but imagine that compounded by unmet behavioral health care conditions, challenged by being homeless, having to navigate not only the healthcare system, but also the social system and having a place to sleep at night. It's really unimaginable. The goal of coordinated care then is really to change from having an individual navigate these complex set of systems. Instead, it's moving towards care that is coordinated at all levels. It's moving towards addressing social needs like housing, behavioral health, substance use, all within the context of healthcare delivery. And it means greater responsibilities across providers for individual patients. And this is what we say is an ideal world of what coordinated care looks like. Issues like transportation and going to the Department of Social Services for food stamps are crucial to the delivery of care and are recognized as being significant in healthcare delivery. The patient's needs are centered here, and programs are designed and working together to meet the needs of the patient. I'll preface this discussion of care coordination by saying that there is no silver bullet. No perfect organization has figured all of this out. All of us really together are figuring this out. At its core, though, the understanding that healthcare requires significant partnerships across multiple agencies and team members to deliver care that meets both social and medical needs is really the crux of care coordination. And so the organizations who have really been working towards care coordination models have found that there are several key components that are required. One, there needs to be an ability to share data that providers need to be able to understand the medical needs of their patients, and that members of a team are able to coordinate care for these patients. There needs to be defined team structure and defined roles and responsibilities across domains. Coordinated care planning needs to involve the patient within goal setting, and the patient has a central role in this work. There needs to be strong partnerships at all levels, relationships between hospitals, primary care, behavioral health, social service organizations, particular housing organizations. These programs have trauma-informed care in their approach, as well as utilize harm reduction practices. So next, I want to give Camden and Heartland a chance and opportunity to talk a little bit about their organization and care coordination model. So I will then give this to Camden to talk a little bit about their work. Janine or Mary?
Hi, Janine and Mary. Don't forget to unmute yourselves.
Hi, are we there now?
Yes, we can hear you now.
Okay, great. So this is Mary. I'm here with Janine. I'm going to do a bit of an overview of the Camden Coalition of Healthcare Providers. We are located here in Camden, New Jersey, and our overarching mission is to improve the quality, capacity, coordination, and accessibility of the healthcare system for all residents in our city. And that's coupled with our vision of being the first city to bend the cost curve while improving quality. So that harkens back to what Liz was saying about a small percentage of patients accounting for a significant number of costs. And we see frequently when we see the patients with those super utilizing patients that they are experiencing really fragmented care that isn't integrated across systems. We are a membership organization, so we are truly a coalition. We have members from across the city and the different organizations and hospital systems in our city as a part of our organization. Where we have a staff of about 75 people. We also have some AmeriCorps members. And while Janine and I are from our patient-facing team, our care management initiatives team, there's other teams and staff in our office working at kind of the meso and macro levels as well to address issues more citywide and even statewide for our Medicaid population here in New Jersey.
Next slide, Liz.
Yeah. So this is how we frame or describe our team and what we do. It is community-based. It is multidisciplinary care management for vulnerable populations. So this is one of our community health workers out at a home visit. And I'll kind of go over our team structure next. So this is our team. It's like a Venn diagram. We have two clinical teams with an RN clinical manager and a program manager who's looking more operationally. So that RN is giving more of the clinical support, while the program manager is keeping us on track with operations, metrics, things like that. And then licensed practical nurses, or LPNs, partnered with community health workers. We go out into the field in teams. So they are the core teams that we have going out into the community, meeting with patients. And more recently, I would say over the past 2 years, we've built out a significant social work presence to provide support and integration for our social service needs that our patients are facing. So we have a social work manager who's managing a social work group that includes social workers, a behavioral health consultant who is a licensed psychologist, and then I'm working more on our kind of intake side where we're meeting our patients in the hospital. So that's an overview of how we work. We're very multidisciplinary. While we all have our different areas of expertise, we all work really closely together. And we can talk more specifically about that when we discuss things like care planning later on in the presentation.
Thank you so much, Mary. And I'm going to segue this to Ed to talk a little bit about his work in Chicago.
Great, thank you. So I'm the Executive Director of Heartland Health Outreach, and Heartland Health Outreach is the primary healthcare for the homeless provider for Chicago. And how we're configured is that we're a federally qualified health center. We have 3 health centers, north side, west side, south side of the city of Chicago. But we also engage and serve people and individuals and families experiencing homelessness in about 52 shelters throughout the city, whereby we take healthcare on the road and engage people in providing direct services right there in the shelter. We provide our folks with primary care, of course, but as you can imagine, people experiencing homelessness, that population has really high rates of co-occurring behavioral health disorders, as well as extreme needs around the social determinants of health. So over the 30 years that we've been around, we've little by little braided funding from various services to create sort of an internal network of care that includes primary care and oral health. We have about 250 units of housing, and we have food and nutrition programs. We certainly do street outreach in addition to the shelter-based outreach, and we also serve the members of the refugee population. We have some specialized services there for their mental health. We can move to the next one. So as you can imagine, what we're trying to do internally is use a highly integrated model of care, primary care, oral health care, behavioral health services. Illinois is an Medicaid expansion state, so most of our folks now, about 88% of our folks do have Medicaid. 3 years ago it was the opposite, 88% had no Medicaid. And we work within their managed care network, certainly, to help coordinate care outside of our walls. That said, of the 9,000 to 10,000 folks we serve, you heard me say only 250 are living in our housing. So one of the things that we're launching, and this is still very initial, we're just in the process of establishing it, so I'd love to be able to share with folks maybe in 6 months or so how it's going. But we're launching what we are calling the health neighborhood. So HHO, like many FQHCs, has patient-centered medical home status. We actually achieved a level 3 status, which is the highest status for essentially a model of integrated care on site. And what we think, though, is that our folks need more than a health home. They need a health neighborhood. And what we're doing is we're partnering with the wonderful permanent supportive housing providers who have been our allies for many years. And we're doing a model whereby we are blurring the boundaries between our organizations. And HHO is leasing, and right now we're in the process of negotiating these arrangements, leasing some of their licensed staff, some of their case management staff to allow us to bill for behavioral health services on site, understanding that behavioral health is really important to the folks we serve, and also to help them to lease out some of their case management time to do some care coordination activities within our internal network. And the idea is that our folks will really have enhanced care because all the folks around them are working together. We can go to the next slide. So the framework for the health neighborhood is essentially what we're trying to do is to leverage existing resources in the community that address the social determinants of health for our participants, and using a collaborative leadership structure coordinating those services. The other thing that I haven't mentioned yet is shared data. So we are part of a health center controlled network, and through that network, we have access to a data warehouse into which our electronic health record information flows, and on the other end of that, a care coordination software that is very new to us that we're just about starting to use. In fact, I have a big meeting about it tomorrow. So that, I'm going to stop there because I'm mindful of my time, but that's sort of the overall picture.
Great. Thank you so much, Ed, and we're going to get more into the nitty-gritty as well, so thank you. And so we're at the facilitated conversation portion of this and would encourage you, now's the time as we go through the questions, to feel free to ask your own additional questions through the chat function to all panelists. So we'll be collecting them and we will be going through some of them that we don't answer towards the end of the discussion. Thank you. So, Camden, Mary, and Janine, I will turn it to you. So data was discussed. It's something that I know Camden uses, and Ed talked about the importance of being able to use data in his work. How does data inform your work, and how do you use data in Camden?
Sure. Data really starts from our very initial patient outreach that we're doing in our local hospitals here in Camden. Like Ed mentioned, in terms of our systems we have built out, we have a Camden Health Information Exchange, and that, you know, our local hospitals and other providers are a part of that. So that's a way that we're able to access various health information. And very initially, when patients come on board with us, there's consenting that we discuss with them and releases of information that they're signing to allow us to view health information there, and secondly, to do care coordination on their behalf. So we're explaining it in terms of being able to discuss with their providers and other agencies they're working with to discuss their case and explaining the significance of that collaboration to their better health. Data is also how we identify our patients initially. Because we know we're targeting a specific group of patients, the patients who are really highly utilizing the local hospital systems, who have significant chronic medical conditions, taking a lot of medications.
5 or more medications, 2 or more hospital admissions within the last 6 months. They can be homeless, they can have substance abuse issues, lack of social support, lack of access to supportive services. That does not disqualify anyone from our program, and that's pretty much how we use data in our intervention.
So we're not really taking referrals, we're using that data to hone in specifically on patients that meet those criteria, and it allows us to be really efficient with our outreach.
Wonderful. Thank you so much. And I guess we'll go into goals now, and I'll kind of switch off to Ed, if you don't mind. Ed, now, what are the kind of clinical goals that you're setting forth in your intervention, and how do you envision care coordination helping to achieve these goals?
Sure. So some of the things, so I do want to point out sort of a difference of what we're doing than what our friends from Camden are presenting. So in Chicago right now, we do not have a health information exchange. And the state of Illinois, as most people know, is kind of a little bit in a set of problems related to not having a budget for over a year. And so we don't have a lot of external infrastructure to rely on. So what I'm describing is a little bit of a scrappy, let's take the bull by the horns and just do something for now, right? And so in terms of goals, our goals are, some are very process focused. For instance, starting to look at our group of people as a population, identify baseline, what are the percentage of missed appointments, for instance. Setting a collective, and this is where it's a little different than business as usual, but across this collaboration, setting some benchmarks for wanting to achieve a reduced no-show rate, say, of 20% versus 40%. And then starting to target our interventions and our week work and discussion around reducing those, both on the individual level and the population level, reduce that process goal, the no-show rate. You can extrapolate that a little bit and see where you could apply that same model to picking up medications versus not picking them up, adhering to the medication versus not. That's our first phase. And then in the second phase, we want to set for ourselves bigger goals, health outcome goals. So this is where we're starting to look at, examples would be, for instance, with our folks with HIV, we know that we're constantly monitoring, in addition to them making their appointments and getting their labs, but also are they taking their medication and is their viral load suppressed? So I know right now that we have a 79% rate of viral suppression in our HIV population. And so as we look at our folks who are linked to other providers too, setting those kinds of goals too. So viral suppression relative to HIV, the A1C level, an A1C under 9 related to people with diabetes. There are other process goals related to those things too, like making appointments and getting certain tests, that kind of thing.
Wonderful, thank you, Ed. And Camden, I know that you all too set up clinical goals for your intervention, and you've been utilizing your care coordination model for some time. So I'm curious, have you seen a reduction in costs and utilization and seen an impact through your intervention and improvement for the people that you serve?
So that's a great question, Liz. So we have quite a few goals, and we have utilized quite a few different methods in order to achieve those goals. So some of our goals, our top goal is to, of course, decrease the readmissions for the the people who utilize the hospital the most. So, of course, the top goal is to decrease readmissions, to connect or reconnect our patients to their primary care physicians, to increase the knowledge around medications and medication management, to educate our patients about chronic diseases. Also, most recently, we developed a CHF or congestive heart failure protocol for our patients who have congestive heart failure. And what we did with that was our patients who have that diagnosis, we have a conversation once a week to make sure those patients are aware of that diagnosis. They know who to call, to make sure they have a scale in the home, are checking their weights daily. And if they notice that they've gained 3 pounds or more in 3 days, they know that they're to call their cardiologist or to call the heart failure clinic and what to do in that situation if they received a call back. And if so, what to do in that situation, and if that was a preventable readmission. So that was one thing. And then there was also a 7-day pledge campaign that was started with every primary care facility in the city of Camden, in which every patient who was readmitted to the hospital was given an appointment with their primary care physician upon discharge. So that was shown to reduce the rate of readmission in the city for each patient that was readmitted. I don't have that statistic for the reduction, but I could probably get that from our data team and provide that at a later date. So that was some of the things that was shown to reduce the rate of readmissions.
Yeah, that really speaks to, I think, where Ed was going when you zoom out a little bit, like from the individual patient care plan that Janine was outlining with some of those goals to a bigger citywide goal to really involve our primary care practices in reconnecting patients within 7 days after a hospital admission.
And it's just really impressive that you were able to get at that meta level and involve primary care practices. And curious, what were the barriers to getting folks into their doctor's office in 7 days, and how were you able to overcome that? It seems like there was a significant increase in getting your patients in 7 days. So how did you guys How did you guys do that?
We actually have a team in our office that we call Clinical Redesign, and that is their kind of primary task is building up our primary care infrastructure in the city to enable them to be more flexible, to be responsive in this way. For example, like with the 7-day pledge, they do a lot of weekly meetings with those primary care practices. They review like scorecards to see what's working. I think a huge part of it is that relationship building and education around, the significance of those appointments. I think sometimes they've gotten into routines of, this patient doesn't show up, so but we're trying to make the conversation
about why it's important for patients to come into the office within 7 days of discharge from the hospital. So our clinical redesign team has really been the voice behind initiating this campaign of the 7-day pledge.
And they do some incentivizing as well, and we could get some more information from that team if people have more specific questions. But as part of the ACO, they are able to offer some incentives to the practices to, in terms of giving some more time for those appointments and some financial incentives as well.
Great. Wonderful. Thank you. And so we'll move on, but feel free if I didn't ask your question in that section or you have other questions to put it in the chat box. We already have quite a few. And I want to move on to team structure. That's something that I know communities are really thinking about. How do you design a team? What does that look like? Who's responsible for what? How do you work together as a team, and people coming from different backgrounds, social work and nursing? And I'm curious for you, Ed, as you're building up this team, why did you decide to sort of start small and learn as you go? And how do you view care coordination helping to improve the health of folks who are getting your services in your FQHC? Ed,
I'm sorry. Yep, I'm back. I did the unmute thing. So I think that it's an excellent question. In terms of starting small, what we're trying to do is recognize that as the Healthcare for the Homeless provider in Chicago, we live basically at the intersection of not just the primary care system, but the overall health system, and the homeless services system, the behavioral health systems, because we have multiple here in Illinois. And as a result, we've challenged ourselves to really master those systems, and we actually exist in those systems. So we're a licensed, certified provider of substance abuse treatment. We're a licensed mental health facility. We're also a federally qualified health center and an oral health center. And as we exist in those systems, within our mission, we believe we have to improve those systems to do a better job with people experiencing homelessness. So we try to interpret for those systems the unique needs of the homeless, and also try to link those systems together because they don't always understand each other. They live in silos. So what we've done with this health neighborhood idea is we've reached out to our really close partners who are permanent supportive housing providers and help them understand that a lot of what they're doing right now is what we would consider a healthcare intervention. So reminding people to take their medication, going with them to the pharmacy and picking up those medicines, going for a walk, proper food handling, all these things really dovetail nicely into healthcare. But if these interventions happen on their own without any connection to a kind of a coordinated understanding of how it all fits together, their impact is not optimized. And so we decided that we would start by reaching out to our partners and helping link them. It provides them sort of an incentive in that there are some services that they're providing that are Medicaid reimbursable. And so through a more intensive collaboration, this leasing structure, and actually pulling some of their staff into HHO and our Medicaid billing apparatus, we can actually bill for some of those services. And that helps our patients, too. So it's real reciprocal. And if there's a tri-ciprocal word, because the participant really benefits, too. So the other piece to it is that we really want to make sure that the health care we provide, sure, somebody might come to us 4 times a year and they're really good. They make their appointments and they spend their 20 minutes with the provider and a little bit longer with a care coordinator or a case manager behind the scenes. Okay, so here they are for maybe 4 hours with us. Well, with their permanent supportive housing providers, they have 4 hours a month or sometimes more. And so how do we capitalize on that rich relationship? It's a more powerful bond than we could even have with them.
Great. Thank you. And then, Camden, I'm going to give you the same question, but I'm going to go back to your slide where you really lay out your team structure. And so, I'd love it. You guys are both, you're representing different aspects of the team, and LPN and social work background. So we'd love to understand a little bit more about the roles of each team member on the team, who's responsible for what, and how do you share communication? If you could provide some examples about how you guys work together, that would be great.
Sure. So it actually starts in the hospital. We get a lot of the information from our enrollment specialists, so the relationship building starts in the hospital. Mary does a great job with doing the enrollment intake, and I get a lot of the information about the patient from Mary. I find out most of the time what the patient's needs are, what equipment they may need, if they have any social support at home, if there are any barriers to care, if there are any transportation issues, if there are any issues with pharmacy, just about anything that the patient lacks. Mary finds out, Mary and Audrey, our enrollment specialists, they pretty much, the patient tells them everything. And also we have staff photos that are provided to the patient. So the patient gets a clear picture of who's going to come out prior to them being discharged, so that by the time I get to the home, the patient is aware of who's coming out. So my role upon discharge is to, and that encounter with the patient happens within 72 hours of discharge. So my role is to, that contact starts again within 72 hours, and that's a phone call and a wellness check. And so I go out to the home, I review the discharge summary, we complete that enrollment, and we start the care planning process, which is a backwards planning. And that consists of the patient who would start their care planning. Traditionally, and I'm not saying that there's anything wrong with a provider doing the care planning, because I've been on that side of it. But, sometimes the patients aren't able to make that decision, as to what they want their care to look like. It's usually done for them. But what we do is allow the patient to decide what they want their care to look like during our intervention. So we have a care planning domain. It consists of 14 domains, and the patient decides their top 3 priorities that they want to work on throughout the course of our intervention. And so we work from there. And it can be anything from choosing a better relationship with providers, or getting transportation, medication management, mental health services. There's getting access to food, shelter, benefits, anything like that. And so by the time we finish working with them, we look at where they are on a coach spectrum. From a coach model, it's I do, you do, or we do model. And so by the time a patient graduates from our intervention, we want them to be at a you do, which is the patient is able to do things on their own, which is they're able to schedule an appointment, they're able to call transportation, or they could be at a we do, which is where they can, along with somebody in their family or a supportive service in the community, make those appointments or schedule transportation. And so that's where we want them to be.
That's
our
great.
Community health.
Oh, sorry. Please go on. I was just going to say, how does that caseload look like? Because it seems like you're doing quite a bit of work with individual patients. So what does that look like too, if you wouldn't mind answering that as well?
Our caseload as far as the patients on our panels?
Yeah.
Right now, we have each dyad, we have about 17, 18 patients. And we have a community health worker. We had health coaches who our cohort just graduated last week. And that's about it. We hand off to the social work panel if we feel like our patients are medically stable. If the patients are in need of housing or some other social need, at that time we will hand them off to the social work panel at that time. But right now the average is about 17 patients, and the average patient stays on the panel about 90 days. And some can be longer depending on the complexity of the patient.
Great. And I've been working with the community, and there were challenges with just communicating information. So how are you able to really communicate what's going on with a patient in real time? What does that look like? Do you share a same room, or do you have daily meetings? What do you guys do?
So a lot has changed.
I used to work at Camden, all that.
So we have care planning once a week with the community health worker and the RN. But now we use our database system, our tracking system, which is TrackVia. We're able to use our action board, and we send messages to our social work team, our action items, that we can send a message stating that we need either a social work consult or we need something specific for a patient that needs to be done. We can also send emails. There's a number of ways that we can send messages. If it's something urgent, we can send an encrypted email or anything of that nature. Also, again, we have our health information exchange in which, messages can be read as well. So there's different methods of information that can be, ways we can exchange information.
Wonderful. And I feel guilty that I'm going back to Camden, but I know you mentioned care planning, so I just wanted to kind of stick with that. And you mentioned really how patients are important in the care planning process, and I wanted to talk to you, who is involved in care planning? It sounds like you have metrics you want to meet, and you have community health workers, you have health coaches, you have LPNs, you have social workers. Who's involved in that care planning process, Janine or Mary?
I think, like Janine mentioned, we start right at the bedside when someone enrolls with us with a more traditional kind of biopsychosocial assessment, so that we can gather kind of a baseline of what the patient is dealing with. And then we kind of build out into those different domains where we identify some need. So that might look a little more traditional, like intake type of questions. But really what Janine and the community health worker start doing on that first visit is the more patient-directed. We're in the patient space, we're in their home, and we want them to kind of take the lead. So I think Janine can speak more specifically to how that looks, but that's kind of what we do. An initial overview kind of at bedside, and then we follow the patients out into the community.
Yes, so what we do, we have 14 cards that have goals that the patient specifically want to work on. And like I said, they can be anything from access to food and nutrition, medication, housing, transportation, anything that's important to them at that moment, change in providers, something of that nature. Their top 3 priorities at that time, and we work from that point, and that helps us guide the intervention. And it's more patient-focused versus what we want to work on. I know it's easier for us to state this is what's important for us, but at that moment, it's what's important for the patient. So that helps us to guide the intervention for them, so that it makes the patient feel like they're in control of their health versus, or their intervention versus us being in control. And in most cases, it's a lot easier for us to say, well, you know what, I think this is the most important thing for you, but it's not. And it gives them a sense of independence. And that's, you know, at the end of the day, everybody wants to be in control of their lives. And by the time that, you know, we say you get closer to graduation, we can show them week by week, this is what you accomplished, and it gives them a sense of hope and relief, like, you know, this is something that I was able to achieve. I did this, not, you know, this is what you did for me. This is something that I can see, I can physically see. I accomplished this on my own, you know, with us being a means of support, not somebody telling me what to do.
Great. Thank you. And Ed, I will switch it off to you in terms of partnerships. I know we all have a lot to talk to this point. And folks, again, feel free to type in questions in the chat. We already have a bunch, so I'm excited for the Q&A portion later. But Ed, if you can describe, you have a role as an FQHC. You're also a supportive housing provider, so gives you kind of insight into both worlds. Can you describe, you know, how partnership works and how you're thinking about that in terms of your work at Heartland, but also in developing your care coordination model?
You know, as I was listening to Janine and Mary, I just loved the way they were describing this very participant-centered approach. And, you know, to be honest, building partnerships between organizations really has to embrace about the same values, I would say. So, for instance, in Chicago, you know, in a state that's not had a budget for over a year and providers aren't getting paid, a lot of our permanent supportive housing providers are really struggling, you know, because their funds aren't flowing. And so we know, we have to understand that first and foremost, that's a huge concern of theirs. So how is it that I, as an FQHC, who's able to tap into funds that are flowing, you know, through the Medicaid program, for instance, how can I help them, you know, bridge some of that gap, right? And on top of it, I know that those services that they're delivering are already benefiting my participants. We still operate in a world in Illinois where we get paid for volume, not value. But I know that over time, we will have payment arrangements that will really focus on the value of the services that we provide. You know, what are we achieving good outcomes? And I know that these folks are going to help us do that. And they're already helping us do that. They're already helping people pick up their meds and take their meds and live healthier lives. So I think that from a partner perspective, it's very similar. Where are the pain points? What are people concerned about? What's keeping them up at night? How is it that I look at the world through your eyes and help you? Is there anything in my arsenal here within my FQHC or my behavioral health programs that can help you achieve those goals and allay some of your fears, that kind of thing? Then the other thing, of course, is about shared values. So there's 143 different providers of housing in Chicago. We haven't just randomly gone to all 143. To start this, we've gone to really a handful of about 7 who we know that their philosophy of care is very similar to HHO's philosophy of care. We have a philosophy of care that's built around components like harm reduction, a strengths-based approach, trauma-informed services, you know, embracing and celebrating diversity, and a human rights approach. So we need to, at first, find folks who understand their participants the way we understand our participants, and who treat their folks like we treat our folks, and understand their place in people's lives very similar to the way we understand our place. So I would say values, and then really stepping back and trying to look at the world through the eyes of this other partner organization, and understanding that their problems are our problems. I mean, if these permanent supportive housing providers go under in this very difficult world here in Illinois, that will hurt my participants, which I don't want to have happen. And over time, from a managerial perspective, that's also really bad in terms of us achieving good outcomes, because we know that the social determinants are what really play a huge role in our folks being able to achieve their health goals.
Thank you. And then either Mary or Janine, I'm wondering, you talked about partnership, you talked about primary care providers in the city and your work in hospitals and engagement. How are FQHCs really central to this work, and how do you manage your work with community partners, given some differing goals that partners may have for your patients? What does that look like on the ground?
Sure. I think our FQHC partners here in the city are, like Ed was saying, more aligned with our values and approach. They really know the community and they know their patients. Janine used to work at our Healthcare for the Homeless site here, Project Hope. And they also just offer more, I think, diversity of programming than some of the hospital-based clinics that we work with in the city, or more that are coming out of that more siloed kind of health, just solely health focused. So I think those relationships are a bit deeper and just, feel more like partnerships. That said, with the other organizations, when we feel maybe some folks aren't as aligned with us, we do a lot of modeling. I find myself often in the hospital or, with providers who don't necessarily share those values, just trying to model and do a lot of education around our approach and why we believe it's making a difference for these patients.
That's great. And would love to drill down a little bit on your partnerships. You have a lot of partnerships with social service organizations and housing providers. How does housing work in your intervention, and maybe what are some challenges to that coordination?
I think housing, yes, in terms of individual patients, when we're talking about the intervention, it's something we can often identify very early on in the intervention, usually right at that bedside, the patient saying they're housing unstable or they're currently experiencing homelessness. So we're able to begin to activate things much earlier, often with the involvement of our social work team earlier. We have a lot of partners around a pilot Housing First project we've been doing over the past year, and those partners include kind of Volunteers of America that runs a local shelter system, as well as they own a lot of properties, I think, or lease a lot of properties around the city. Other partners in that are some other behavioral health providers.
Yes, South Jersey Behavioral
Health. They're really leaning in on a kind of what is permanent supportive housing for these patients and how do we provide long-term supportive services. We really have, our role at the coalition has really always been seen as more short-term to making long-term sustainable linkages for patients, so they play a huge role in that. And our patients who have, been a part of the Housing First pilot and are now in permanent supportive housing, we have seen just, what we expected to see in terms of significant reduction in ED and inpatient utilization and improved health outcomes. So we really have, a philosophy that our patients have experienced a lot of barriers in the current system, and the Housing First model really aligns with our mission and vision. And really that a healthcare intervention can't be successful when individuals aren't stably housed. So it's been a huge learning experience. It's ongoing about how we work together most effectively in that space.
I mean, even for the patients, even for the ones who haven't been successfully housed, we have formulated great partnerships with a lot of the local day centers in the community who have been supportive in us in trying to see our patients who frequent their organizations as well. So we've gotten a lot of community support from local organizations who support our mission.
Great. So it sounds like there's both a pilot program for folks that are able to, that you're able to work with in a housing first approach and lean on community partners for that intervention, and then for other folks, you're also, connecting them to resources if you can.
Yes.
Yes.
Great. I will segue to, we talked about trauma-informed care, we talked about harm reduction, and so, kind of switching to Ed, you've been at Heartland for some time working with patients. I'd love your perspective on is there a link and a relationship between trauma and the population you serve, and can you explain if you do use trauma-informed care within your clinical work with patients?
Oh, absolutely. And in our behavioral health programs, we provide trauma treatment too. But from just taking the trauma-informed approach, we believe that it is likely that all of the people we serve have experienced trauma, and we actually believe that homelessness itself is a traumatic experience. Now, the trauma-informed lens means that we make the assumption that that exposure to trauma may have had a significant impact on the way the person understands themselves and the world around them and interacts within that world. It may have contributed to the way they cope with challenges, and certainly it may influence and affect the way they negotiate relationships with service providers or authority figures. So looking at things through that lens, we take a really highly individualized approach. We don't assume that trauma has made this such an impact, and we don't assume that every trauma survivor reacts or responds in the same way. But I'd like to go back to some of the points that I think Janine, you were saying this. But this idea that choice is power, and so that when people have experienced trauma, and very often, whether it's at the hands of another person or it was like an experiential trauma of like a loss, they've felt that their power has been taken away, and so even when the options are very limited, we try to always present everything as an option, that you have the choice. You have the choice, even if it's as simple as to engage or not to engage, it's your choice, that you're the driver. This is your life. You're the expert in your life. So that's the lens through which we look at everything that we do, that, we really, first and foremost, have to really empower people.
Yes, that's great. Thank you. So I want to just remind folks we are here for 15 minutes after the hour, so we're ending at 3:15 Eastern Time. So I'm going to ask one more question to Camden, and then we're going to go through some of your questions that you've been asking through the chat box. I'd also say if you have more, please feel free to add them to the chat box. We're going through them right now. And so Mary or Janine, and my mind is going to Janine just because I think we've talked about this before, but wondering if you can speak to how is harm reduction important in working with the patients that you serve? Are there examples that you have where harm reduction has really been important in terms of building trust and helping to improve health for patients?
That's a great question. I think the thing that stands out most to me is when working with someone who is actively using, a lot of times people want someone to stop. And, you know, the one thing I would have said to someone is, are you aware that there's a needle exchange program locally? You know, are you practicing safe using behaviors versus do you want to stop? You know, the goal is to, you know, not stop immediately, but to practice using safely. There's no judgment here. I think people are so used to jumping down somebody's throat and not being understanding, and to be so judgmental of someone and not meeting people where they are, versus I'm going to help you and I'll meet you where you are. I just want you to be safe in what you're doing, and we'll help you.
Have there been examples where maybe physicians that have seen patients who may be using haven't utilized the harm reduction approach, where you have had to sort of re-engage patients in that way?
I think there have been times where physicians have been really frustrated. You know, patients have stated, I'm going to quit, this is my last time, I'll stop, you know, I promise this has been my last time, and patients have relapsed, and it has caused physicians to become frustrated and maybe have come to a point where they've given up, and, you know, patients are like, well, you know, they're not going to listen to me, and we come in and patients have said, well, you're going to be just like everybody else, and that's not the case. You know, we're not here to judge a patient based on their past, and it's like, you know, the patients are traumatized, physicians are traumatized, and, you know, we're just here to reduce the harm. So it's like I'm saying to the patient, I want you to practice safely. We're going to help you through this process. It's not something that can happen overnight. I understand you didn't start this yesterday, so it's not something that you can stop easily today. So the goal is to slowly reduce something that you started so many years ago. But I think the mindset has to change. I think it's just that people are frustrated with the process of trying to get someone to stop, and it's just not something that's going to stop immediately. It's something that started years ago, so you can't just change something that started years ago. It's just not going to stop instantly.
Right. Well, thank you, everybody. And so we've been getting a lot of questions in the chat box. Feel free to send more now. If we don't get to your question, if that's okay, we're going to, following the webinar, we compose every question and speak to our panelists and get the most information we can for you. So if we don't answer your question right away, we will provide follow-up information for you. And I will pass this to Lauren Berner at the National Healthcare Council to take over the Q&A discussion.
Thanks so much, Liz. Hi, everyone. As Liz mentioned, we've gotten some great questions in so far. Please keep submitting. Love to kind of get as much out of this discussion as we have. We have about 10 minutes left, so I'm going to try to get to as much as possible, and we will definitely send out the questions we don't get to, so do not worry. We will get to your question eventually. It just might not be today. One quick one that came in for Ed. Are you familiar with CMS's regional budget payment concept, and have you guys considered looking into that at all with the health neighborhood structure?
Oh, Ed, you might be on mute.
So I was not familiar with this. So I actually, as that question was coming through, I was writing little notes to myself that this is something I'm going to be doing right after this webinar, and it's so great that we have these national forums. So no, I'm not familiar with that.
Perfect, yeah. And that is something we can definitely include as a resource. When we send out the Q&A, I'll find a link to that. It looks like they are currently taking comments on this, So if you guys want to take a look at this later and see if you have any comments or suggestions, then CMS is willing to listen, which is great. And then, so moving on to the next question, what are some of the strategies that you all have used that have been most successful in engaging patients and their families in this process? Because as we know, care coordination is patient-centered, so how have we engaged those individuals? And maybe Camden, if you guys want to start?
Sure. Some strategy. Well, are you talking about as far as enrolling patients initially into our program?
Enrolling initially, how you keep them engaged, what has been successful for you guys?
I think just establishing the relationship. I think some of the things that, just the consistency. Once we graduate the patients from the program, we ask a series of questions. You know, what's worked with our program, or, you know, what can we do differently? And some of the things that the patients have stated were that we were consistent. We kept coming. We didn't change. We were engaged with them. We accompanied them to their appointments. We were supportive. We were just present.
I know Janine can speak to this more, but we have developed kind of a philosophy that we use with patient engagement that's called COACH. And the C stands for connecting tasks with vision. So that would be like if a patient in that initial goal setting is talking about something like spending more time with grandchildren or reestablishing connection with some kind of community, we're able to like make that direct connection back to some of the goals they outlined, especially health-wise. And the O, which I think is really important, it speaks back to what Ed was saying earlier, is we're observing the patient's normal routine. We are going in not with our agenda, but really seeing how they're currently doing things, and we want to enhance that, or like, you know, we're not coming in with our agenda. I think that really helps. And when we do see a patient, you know, struggling with ambivalence about making change, we always, you know, our go-to thing would be a motivational interviewing style. I think that's huge because, again, it empowers the patient to make that change instead of it feeling forced on them.
Right, yeah, that's a huge part of this. Ed, did you have anything you wanted to add to that?
I love what I just heard, and I would say it's really consistent with what we do. We always talk about relationship first, right? So especially for people who are experiencing homelessness, they really want to build that relationship. They really want to know that we're listening to them. Again, it kind of gets back to that personal power piece. The other thing is that I think that as providers we have to understand that unless someone's in pain or bleeding, if you don't know where your next meal is coming from or where you're going to sleep that night, healthcare is probably not your #1 goal, even if your blood pressure is sky high. So how do we help you address that main goal, which is usually kind of like a social determinant, right? And then by so doing, to what extent do we strengthen that relationship? So if I can help you get what you need, you may be more interested in working with me on trying to access some of these other things that you may need, but they're a little bit further down your list of priorities.
Yeah, absolutely.
Perfect. And then, so a big part of this, again, is working with partners and stakeholders, and that includes consumers and your other partners and just other community and national stakeholders. So do you guys have any mechanisms in place that you use to kind of get stakeholder input and feedback?
I could jump in here. So we have, well, in terms of our participant population, we have a couple of different ways. We have a consumer advisory board, and in fact, the consumer advisory board elects a consumer to sit on our governing board for our organization too. In addition to that, we have sub-consumer advisory boards in our different corners to kind of a deeper dive into our operations in different sectors of HHO. And then another thing that we do, understanding that not everyone's going to participate in a formal board, we do focus groups too, and then surveys and things like that. That's at the consumer level. Now, we haven't, as you asked that question, I realize we don't really have that kind of feedback mechanism for our partners right now, and that's probably another thing I have to put on my little list here.
We also have a consumer advisory council. We have a formal board. We also have our we engage our patients as well. We have some of them come in and, who offer suggestions as well.
Yeah, in terms of our more like external partnerships and governance, I think we could, if there's questions about that, we could definitely consult with one of our colleagues on our kind of community engagement group. But we do have at various levels, a lot of consumer involvement. We have a staff member working with a lot of our local churches.
Faith extension.
Yeah, there's various levels, but we could definitely get some more specifics on that. But part of being the ACO as well, there's just a lot of collaboration happening and engagement at various levels in the community, and again, even beyond to the broader state population.
And I would imagine that a lot of kind of this feedback and input would be a little bit more informal as well. When you're discussing care plans and things like that. So thank you. Moving on, so I can try to fit another one in. Camden, you mentioned a lot about, or some about your health information exchange and kind of having that information sharing process set up. How did that kind of get developed? Like, where did it start? And then is this kind of set up where it's unique separate databases that are within the EHR that the EHR connects to, or just kind of what does that structure look like, kind of quickly?
Yeah, it is. Again, this is not our exact area. We utilize the system a lot, do our work. We do have a staff member who's solely focused on it, but it does pull in information from our local electronic medical records. So it's like there's some kind of, it just allows more shared clinical information across different health systems. Like we find with our population, a lot of our patients will go to multiple hospitals in the area. So that's like a huge barrier to care coordination if you don't know that someone has just recently been in another local hospital. So it is a separate entity from the EHRs, but it's drawing from those EHRs from, I think, 5 local hospitals in our region. Again, we can link get some more information from the manager of the health information exchange. But I mean, for our work, it makes a huge difference.
But not everyone has access to that information.
There's a lot on the back end that has to be done with, protecting patient privacy and HIPAA training and various things, but it's built to ensure that only healthcare providers have access.
Okay, great. All right. Well, it looks like we are running up against the end of our time, so I'm going to pass it back to Liz for a couple last notes. But thank you all so much for this really great conversation, and thank you everybody for your questions.
Great, thank you, Lauren. So as soon as the recording is available, we will send you a slide deck. A lot of folks were asking about that. A link to the recording and then answers to these questions. And we'll definitely provide some of those resources on the Health Information Exchange and the data that Camden uses, which is a great follow-up information. And our next webinar is also focused on care coordination. So this really got into the clinical aspect. So how does it work? What does it look like? Next is going to be how do we pay for it? So we'll be talking much more in depth into how we're financing these models and moving towards sustainability. So that will happen August 25th at 2 p.m. So encourage folks to register to that. Next, there'll be a pop-up window that should appear after you get out of this screen for the webinar, and that will survey on your experience on the webinar. So feel free to let us know what you think, and this helps us continue to create worthwhile webinars for all of you. And then finally, you know, CSH has a national cooperative agreement with HRSA, and so our focus is to really help health centers improve service delivery through health and housing partnerships, and that was really the goal of this webinar today. So I just want to thank you so much to our panelists, Ed, Mary, and Janine. Thank you so much for your time, and with that, this really concludes our session today. Thank you so much. Have a good day, everybody.
Thank you.
Thank you.